Shall we start?
Swapna ma'am needs 5 minutes. She's just reached home. And Kinley has not joined, no? Has she joined? No.
No, I can't see her.
Yeah, so Kinley is not joined. Mohan sir, okay, Mohan sir has come. Okay.
Yeah, Mohan sir is here. Good evening, sir. Mohan sir, good evening.
Mohan sir is here. Sir, where are you? And Dr. Deepthi is here. She's our moderator. Where did she also go? Yeah, she's here. She's the infertility specialist. And who else? I can't see. Where's Resmi ma'am?
Can't see her.
Yeah.
Can you hear me?
Yeah, sir, we can see you. We can hear you.
Oh, great. Okay. So the chief guest is from Bhutan, huh?
Yeah, sir. She's the national chair of Spice Road Bhutan. She'll just be joining us.
I need to talk to her.
Okay.
I've spent 2 years in Thimphu, Bhutan.
Oh, okay.
My wife has also worked in their National Referral Hospital, JDWNRH.
Oh.
Maybe, I don't know, we would have met, I'm not sure.
She is actually doing her family medicine now.
Achha, she's doing family medicine. From where? There only?
Yeah, there only. I don't know which institute.
Generally, they used to go to Sri Lanka for family medicine course.
No, she's doing it there only. She's doing it there. She's I think, I don't know, second year or final year, I don't know. Final year, I think. Smita, you'll be sharing the slides, no? Yeah, actually, Smita, before you, Dr. Kinley will be doing her presentation. So after that, you can do. Rao sir has come.
Where is Rao sir?
So he's just logged in. I think it'll just be connecting.
Long time since we have seen him.
Yes.
How many logged in now? Till now?
47, sir.
47, good. What was the last time, I think, classroom attendance?
120. 120. 120.
So let's see whether we'll break that record today.
Yeah, we are live on YouTube as well. So hi, sir. Rao sir is here. Welcome, sir. Thank you for joining us.
Rao sir, hello.
Sir's mic is muted.
No, I think I unmuted it and Seren muted it.
Yeah, I have.
Hi, Seren. Kailas.
Hi, sir.
All busy?
Sir?
Oh, audio is not clear.
It's not his or once again. Sir, can you hear us?
Yeah, I can.
Yeah, we can hear you now.
Sir, शक्ल तो दिखा दो अपना.
So it's there. His camera is on.
His camera is on, so I am
Yeah,
not
yeah.
able to see.
You can probably
Yes,
have
yes,
just
sir.
shift the screens.
Hello, sir.
Yeah. I can see you, but can you?
Yes, yes. Now I can see you,
Yes.
sir. I think. How are you, sir?
I'm good, thank you. Pulling on,
Okay,
watching
sir.
you all, watching all the progress.
Hi, Rashmi ma'am.
Rashmi ma'am has
Welcome.
just joined. Where? Kailash, can you just call Kinley?
Yes, sure.
Hi, sorry, I'm here.
Okay. Sorry, didn't see you. Thanks.
Welcome.
Technical issue.
Oh, she's also spice route. Okay.
Okay. There are so many spice routes today.
I
I'm not
know.
able to identify. Has Swapna ma'am joined?
No, she's not yet. I'll just quickly call her. 1 second. Swapna ma'am is just.
Dr. Kinley video is not there.
She's there. It's there, sir. She's there. She's.
Dr. Kinley. Hello.
Hello, hi, I'm here. Good evening.
Yeah. Kuzuzampala.
Kuzangpula and namaste and
I served in Thimphu for 2 years, so that's why I know Kuzuzampala.
oh, great, sir. Nice to know that.
Yeah, my wife worked in JDW NRH.
Oh, great, sir. Great.
She's worked in the Royal College of Health Sciences, no? RGH also.
Yes.
RCH. So where are you doing your training, Dr. Kinley?
In Thimphu itself, sir, we have only one
Thimphu?
university. Yes.
Okay, in Thimphu. Okay. So in a medical college, huh?
Yes. The only medical university in the country.
Yes, I know that. Yeah, it was just coming up when we were there.
Yes.
Is Dr. Sharma still there, the physician to His Highness?
I don't think so. I think he had left.
Okay, he's retired. Yeah.
Swapna ma'am has joined. Hi, ma'am. Swapna ma'am.
Shall we start?
So we'll start. We'll start.
Audio, my audio there?
Yeah, we can hear. It's audible. Okay. Good evening. Welcome to the second Spice Route India classroom. And this is being hosted by Spice Route Karnataka chapter. Warm welcome to all of you here. Today we'll be trying to focus on gynecological cases, and for that we have with us a gynecologist. Then we have our moderator, another moderator, Dr. Swapna. We have our chief guest, Dr. Kinle, who is the national chair of Spice Route Bhutan. So first I want to invite Seren to welcome everybody to the gathering.
Hi, good evening. Welcome to Spice Route India classroom. So we are conducting classrooms on a monthly basis, and this classroom is organized by Spice Route Karnataka. So let me make it short. Today we have our chief guest, Dr. Kinley, who is the national chair of Spice Route Movement, Bhutan. Welcome, Dr. Kinley. And we have our moderator, Dr. Swapna, who is a practicing family physician from Bangalore. Currently, she is the HOD of Family Medicine Department at St. Philomena's Hospital. She is also the president of AFP Karnataka chapter. Welcome, Swapna ma'am. I'm not able to see her.
Yeah, she's there. She's there.
Hello, ma'am. Welcome, ma'am. And we have one specialist moderator, Dr. Deepthi Bhava, who is a practicing infertility specialist from Aster CMI Hospital. Welcome, Dr. Deepthi. Can I see your face?
She's
Okay,
there.
thank you. Welcome. And Dr.
Thank you.
Dr. Smita Alice Jacob, who is a final year resident at St. Philomena's Hospital, who will be presenting the case. Welcome, Dr. Smita. And welcome all seniors. Rashmi ma'am, BC Rao sir, Indu ma'am, all seniors and all state leaders, all dear members, welcome to Spice Route India classroom. Thank you.
Okay. Dr. Kinle, can I invite you to speak to our audience?
Okay, Kuzangpo, am I clear?
Yes, yes, you're clear.
Good evening to everyone, all the distinguished speakers, and thank you, Jyotika, for giving me this privilege to be able to speak in front of all the learned and distinguished speakers and the learned physicians. So I'll just address a little bit about the GP program and how it is in Bhutan. Can you please share my presentation, please?
Okay, just give me 2 minutes. Do you have it ready on your screen?
Yes,
You can share it.
Okay, sure. Just give me 1 minute. Okay, so like so I'll just tell you about the GP program in Bhutan, not related to today's theme or anything. So you all know that Bhutan is a very small country, and India had been a very helpful neighbor to the country Bhutan. Just to say the overview of GP in Bhutan. So the whole population of our country is only 8 lakhs. It is a landlocked country. Am I clear? Sorry, it's echoing back. So it's a landlocked country, and then we have total number of only 400 countries and total GP. Our country is very small, and we're still working on improving the GP program in Bhutan. So as of now, we have only 6 general physicians, and then GP program started first in 2017 with a lone candidate. That's myself. I was the first GP candidate to take up the GP program in Bhutan. So this is the National Referral Hospital in Thimphu, which is also the only training center for the doctors in Bhutan.
Actually, we're not able to see the screen, Kinley.
I did share. Uh, okay. Can you do
Yeah,
that?
I'll just try. Yeah, I'll do that.
We can see now. Punaka.
Is it visible?
It's visible now.
Yes. Hello.
Yes, Kinley, you can continue.
Okay.
Yeah.
But I'm not able to get in. Just give me a few
This one?
seconds.
Can you see the screen, Kinley?
Yes, but it has I had some problem here.
Can you see this National Referral Hospital, Thimphu? You want me to stop here?
Just give me 1 second. I'm not able to. Okay, got there. Okay, so yeah. So I was just talking about the National Referral Hospital in our country. It is a 350 bedded hospital, and because it's a small country, it is also the only teaching hospital in the country where I'm getting trained right now. Can you change the slide, please?
Yeah.
It's not in slide share mode. It's just coming. Only the first slide is seen for me.
Can you see this now? Bhutan becomes Wonka academic member.
No.
I tried to share from here. So let me see. I can.
Is my screen visible?
I could just see GP in Bhutan as the first slide, an overview of GP in Bhutan. It's not in slide share mode.
Now?
Now I shared. Is that visible?
Let's just refresh myself. Yeah, now we can, yes.
Okay, so I just wanted to share that though we are a small country and a small GP group, we also became the member of the Wonka academic member in 2017 with the visit of Michael Kitt. Can you see him there? Is
Yes.
everyone aware of the Wonka
Yes.
organization?
Yes.
Thank you.
Yeah.
Yes. So this is how we became the member of the Wonka organization. And then the next is because it's a very small family and because it's a landlocked country, GP is the only physician that can help provide holistic care to our people because it was landlocked and then it was very difficult for our people to seek all care at once. So GP was the only physician that can give wholesome care to our people. So our country is really trying to bring up this GP program. And then when it first started in 2017, I was the only candidate who took up the GP program in Bhutan. We had 3 faculties previously, but they were all trained in either two were trained in India and one was trained in Nepal. So everyone was trained in outside, and it was very recently that training had started in Bhutan. So we still have a long way to go, and we're like really trying to go there and then reach the goal of helping the country and serve our people. So this is when we first joined, when two of my juniors joined, and we had the GP program in Bhutan because it's still, we need lots of motivation, advocacy to our juniors. We are trying hard, and then we do visit around a lot. And then the other picture I was shared is the Raman Kumar, the chair of family medicine in India.
AFPI India. Yeah.
Yes, so that was when we met him in Nepal last year during the emergency symposium they conducted. So that's it. Thank you for your attention. I'm sorry for the technical issues.
No issues, I think. Yeah. Thank you, Kinle. Thank you so
very
much.
much.
We will start with our case presentation. So we have Dr. Smita, who's the final year resident at St. Philomena's Hospital, Bangalore. So she has prepared for 2 cases. Both are gynecological complaints, as you would have read in the poster that we had. The first case she's going to discuss is about a young girl who comes with some menstrual irregularities. And the second one is a case of primary infertility in a 29-year-old lady. So let's listen to her.
Hello.
Yes, Smita, we can hear you. You can.
Yes.
You can load your
Good evening,
PPT.
everyone. I'll start with. Yeah, already loaded.
PPT is not come
Is it
yet.
visible?
PPT has not come. Only the previous screen is visible.
Is the PPT visible for you, Smita?
No, ma'am. For me, it's visible.
Then you have to share it, no?
I shared, ma'am.
Try once again. Go back to your main screen and try once again.
Okay. Can you see my screen? Can everybody see the screen?
Yes.
Yeah. So Smita, I'll share it. No problem.
Okay. Good evening, everyone. The first case is a 19-year-old female has come to the OPD with complaints of irregular cycles and heavy bleeding for many days since 1 year. Age of menarche is 15 years and menstrual cycles 15 to 25 days in 2 to 3 months, and LMP 20 days back, still ongoing flow, changing around 4 to 5 pads per day. And there is also, she also gives a history of passage of clots, no weight gain or loss, no pain abdomen, breathing difficulty, or pedal edema. Ma'am, can you hear? Past history, nothing significant. Family history, her sister has similar complaints. Personal history, stress for degree exams, no exercise, and she's on a non-vegetarian diet. On examination, she was obese, BMI of 32, weight she was 73 kg with a height of 152 centimeter, and she had acanthosis nigricans and no hirsutism, and she was pale and no signs suggestive of hypothyroidism.
Smita, just hold on. I think
yeah.
there is some issue with the slides. I'm also not
Slides,
able
ma'am.
to see. Somebody else is
Yeah. Even mine is not moving. 1 second. Is it visible now?
No,
Is it
please.
Yeah,
Now it is visible. Yeah.
Yes, yes.
Which slide is visible now? Case 1.
Case
Case
one.
one. Case one.
Okay.
I can
On examination, she BMI of 32.
that slide is visible.
Okay.
Jyotika, please mute all others, okay? Please mute
Yes,
all
sir.
others. Because there's some
Yes, sir. Seren, just unmute Smita.
Yeah.
Yeah, continue Smita.
Yeah. On examination, she was obese with BMI of 32. Her weight was 73 with height of 152 centimeters. She had acanthosis nigricans, no hirsutism. She was pale and no signs suggestive of hypothyroidism. And
It's getting
ma'am,
stuck.
the next.
Yeah, 1 second.
Yeah, yes, ma'am.
On your side, you have done stop sharing? Yeah, okay.
Yeah, I've done.
Yeah.
And coming to the investigations, her hemoglobin was 7.4 gram per deciliter. Peripheral smear showed a microcytic hypochromic anemia, and TSH was 2.1, which was normal, and iron profile suggested of iron deficiency anemia. Her ultrasound abdomen and pelvis showed multiple follicles in both the ovaries with ovarian volume more than 10 cc.
Okay, ma'am, you can take it from here.
Thank you, Smita. So we have a young girl here who has been in trouble since the time of her menarche, almost 1 year after her menarche. And she came with severe anemia. And her concern was that the cycles are going on for so many days, 25 days. So considering the diagnosis based on the scan as a PCO, let us take it as a PCO based on the scan, and her other reports are normal. Okay, now what are the other tests that you would like to do for this patient? Smita, you can start contributing. Yeah. Meanwhile, I would encourage the young doctors here to put up in the chat box your thoughts without deviating from the subject. We are going to concentrate on PCO in a young girl with menorrhagia and polymenorrhea kind of picture. So please put in your thoughts. TSH is already done and it is normal. That is the first thing I get. Of course, we knew that would be that. But what are the other investigations that you're going to plan? Okay.
Prolactin.
Yes,
prolactin.
Prolactin.
And they already told ma'am FSH and LH ratio, and fasting insulin.
Okay.
And free and total testosterone levels. And also her lipid profile.
Okay.
Because we are thinking about metabolic syndrome also. Then her her fasting blood sugar, PPBS, and probably an HbA1c also.
Okay. So we have got some other, almost whatever Smita has told, many people have also responded with somewhat similar. So let's start discussing one by one. So what would be the role of prolactin here? How is prolactin going to help us?
Hyperprolactinemia, ma'am, we have to rule out that, ma'am. But in PCOS, there may be prolactin will be mildly raised, not in the level of any micro or macro adenoma. Or it can be due to even prolactin can be increased in mostly the most common physiological thing is pregnancy during lactation. Otherwise, it can be increased even during stress also. But we have to rule out hyperprolactinemia.
In this patient, how is it going to help? Is prolactin going to be? Dr. Deepti, I hope you can chip in at this time. So among the investigations that has been mentioned, we've got, I hope you're able to see the chat, Dr. Deepti. Serene, you will have to unmute Dr. Deepti.
Yeah,
Unmute.
unmuted. Yeah, she's there.
Okay. So we are seeing, from the audience, TSH was the first one. Definitely agreed. It's of no, we've already told it's normal. Prolactin, serum FSH and LH. Ratio, somebody has written FSH LH, somebody has written ratio. So which is important? Is it separately FSH LH or are you going to look at the ratio?
See, to begin with, this patient is 19-year-old, and so she's just about getting her cycles back to normal, as in the HPO axis is just getting to normal, because from the time of menarche she's having this irregular cycle, and if you see, after a long time she's getting this heavy bleeding. So 3 months, 2 months, she's amenorrheic, and then she has a bleed. So normally when you are amenorrheic for a longer period, definitely the estrogen is very high, and that is why you're shedding it for a longer period. So there is unopposed estrogen there, and the progesterone is not enough. There's more of estrogen and less of progesterone. So yes, to go back and see where is the problem, whether it is hypergonadotrophic, and since you have evidence of PCOD in this patient, in normally at least 50 to 70% of PCOD patients, LH is raised rather than FSH. So if you do FSH and LH, and that has to be done on a fasting sample and on a day 2 or a day 3 of their cycle. If you do it randomly anytime, that won't be correct. So on a day 2 or a day 3, a fasting sample taken at on a standard lab, that would help. And generally LH is very high compared to FSH. So that gives us an idea that there is a this could be a PCOD component. And at the same time, if you do an estrogen in the early cycle, estrogen also will be very high. So this can all of this will be showing us that we are looking more towards PCOD. Of course, you have to rule out other things. So that is when the ratio matters. When LH is very high compared to FSH, the ratio also helps us.
So because of the high level of estrogen compared to progesterone, these patients are more even prone to endometrial hyperplasias. That causes
Yes.
that causes the menorrhagia. They're even prone to endometrial carcinoma. So when we come to treatment, we will talk about that as to why we should treat these kind of patients, why we cannot leave them alone. So there are some thoughts on testosterone.
Testosterone, yeah. Can we take one question that whether testosterone needs to be done at this level?
So what would be the best test? Whether it would be testosterone, total testosterone, whether it will be free testosterone, whether it will be DHEA, whether it is going to be SHBG. Smita, what is your idea on that?
DHEA will be better, ma'am.
Androgen index. So what would be the best test to do for this patient, and how would it contribute in your diagnosis?
DHEA will be raised, ma'am, and sex hormone binding globulin will be reduced, ma'am. So that will contribute to the more estrogen, more testosterone levels in the body.
Okay, so what would be the best test?
DHEA will be best.
DHEA will be good, best, or will it be the index?
Not sure, ma'am.
Okay, yeah, Dr. Deepti, your thoughts on what would be the best test to do in terms of hyperandrogenism?
Yeah, so to confirm first the diagnosis, whether we are looking at PCOD or something else. So as compared to the definition of PCOD, 2 out of 3 things should be positive, and one of them is either a biochemical evidence of hyperandrogenism or a clinical evidence of hyperandrogenism. So if she's having clinically very clear signs of hyperandrogenism like hirsutism, acanthosis nigricans, and things like that, then we know it's not a must that we go ahead and do it for everybody. If we have a clinical diagnosis, that's good enough. But in case you want to rule out other reasons of hyperandrogenism, like congenital adrenal hyperplasia or Cushing syndrome, or other causes like adrenal tumors can be there. So in that case, these things help. So total testosterone and your SHBG levels do help. But if you want to rule out other things, then of course other hyperandrogenic features and biochemical parameters come into the picture. But generally, for if it's a very clear cut PCOD presenting with the typical hyperandrogenism features, symptoms, ultrasound factors showing symptoms like PCOD, then you don't really have to push her to have a clear cut what is that investigation. Clinical evidence is good enough. But
So-
only to rule out other factors, you may have to do this, because it's
So
a
we can
costly and
infer-
not that 100% it will be positive also.
So we can infer that in this patient, maybe it is not needed until unless we really want to look
Yes.
into another cause. So here, when the cause is very evident, we probably don't need to look into it. Okay.
Right. But one more thing in the history, why she mentioned that her sister also probably is suffering from similar episodes. So if you have a sister's history and go by, if she also has a similar PCOD picture, then it's fine. But if you want to again rule out other causes, then depending on how she is behaving, then you can go ahead and try and find out more.
Okay. So that is about
Fasting insulin. Ma'am. Fasting insulin.
Yes, that is another thing is hypermetabolism. I mean, hyperinsulinemia. That is another feature of PCOD. So, in order to, like, if the patient is obese and showing features of PCOD, then fasting insulin with fasting blood sugar, there is a ratio for that also. So, if you do that, you will biochemically again you're inferring that this patient has hyperinsulinemia and you need to treat.
okay.
Thank you.
So I guess we got a fairly good idea about what investigations to be done. So we will go to the next session, thought, that is what is going to be the treatment goals for this patient. We will discuss about the clinical guidelines for diagnosis and treatment in the end if we get time. So in this patient, what would be your treatment guidelines? Sveta, what's your thoughts on that?
The first and foremost will be lifestyle modification, ma'am.
What's going to be your treatment goal for this girl?
For her, obesity, ma'am. First, obesity, and also I would like to do a PHQ 2 or PHQ 9 to rule out whether she's depressed also, ma'am, because it's we have to take care of that aspect also. Then lifestyle modification, like about her diet, about exercise, mainly that, ma'am, and exercise 150 per week, like moderate activity, or 75 with higher activity. 75 means per week.
Okay. So in this patient, we would also be looking at further cycles to be regularized, correct? So your treatment goal will be to regularize
yes,
her
ma'am.
cycle to get her weight down, like you said, with whatever.
And anemia also.
Yes, to correct her anemia, because
Yes, ma'am.
of course the underlying cause of
Anemia,
anemia is her increased
Cycle.
cycle. So that would be one goal. So once you get the cycles regularized, we are hoping that the anemia will also settle down. Okay. So that
yes,
comes to the next questions. What are you going to give her for? Let us leave aside anemia correction at this point, because
yes,
our discussion is going to focus on PCO only. So we'll not discuss
Yes,
on the other I would say clinical parameters apart from PCO management. Okay.
Yes,
so what are your treatment options as far as the PCO in this young girl is concerned? What
we
are
have to
your
regularize
things that you have in your medication list?
We have to regularize her cycles, ma'am. So OCP will be the first line of treatment for her, ma'am. First approach.
So what would be the OCP combination that you would prefer for her? Would you like to give her estrogen combined, or would you like to give her only progesterone? What would be the best?
Combined, ma'am. Combined.
Okay. So yeah, what is the basis of giving the combined?
Because the PCOS is a condition of hyperestrogenism, ma'am. So we have to give combined OCP, ma'am.
Okay.
To regularize the cycle. The cycles has to come back to the norm.
Okay, fine. So is there any particular choice of combinations that you would like to give?
Choice. With the newer progesterones, ma'am?
Yeah, estrogen also and progesterone also. Is there a particular choice of the hormones that you would like to give? Okay, let's take Dr. P's opinion on this. What would be the best choice of the combined pills, or progesterone only, or older estrogens, newer estrogens?
See, since she has come to us with excessive bleeding at this point of time, it becomes very important we stop her bleeding at this moment. So it is better to put her on tranexamic acid or something that can stop her bleeding immediately. And to maintain that, we can put her on progesterone only pill. Okay, so that you can start with medroxyprogesterone, TID or BD, depending on how she, how much she is bleeding. And then also you can look into the ultrasound report as in how much endometrial thickness is there. So if the thickness is more, probably you have to require to put her on a progesterone for a prolonged period. Otherwise she's almost finished shedding and then she's not going to bleed anymore, then you can give for a few days with Tranexa and watch. And if it is stopped, then you don't have to put her immediately on progesterone. But first choice would be progesterone only pill for her, because she's a young girl. And if it is just about HPO axis getting back to normal, and if she's following her lifestyle, diet, and losing weight, I think only progesterone should help her. It is not important or not necessary that you start on OCPs right away, because OCP, whatever said and done, you're also adding estrogen, because estrogen is already there in a body. You don't need to put it. It's not a must. But that's easy to take, and that is the reason we put them on OCPs. And when we put her on OCP, if she's more of a hyperandrogenic patient, then we can add her on anti-hirsutic drugs like ciproterone acetate combination, like you have Diane 35 and Crimson 35. So those combinations help better in patients who have hyperandrogenism. And in patients who are obese, who have more of insulin resistance, you can put them on OCPs, which contains more, less of, what do you say, like Yasmin. So it desogestrel combinations that will help them. So you have to categorize your patient onto which way they fall into, and regarding looking into those parameters, you have to start them in OCPs. And that's a long-term treatment, because at least 3 to 6 months patient should be taking that. And OCPs itself is known to be increasing their weight. So you have to choose your OCPs very clearly, and should really advise them that they have to take it for some period, and during this period they have to change their lifestyle. Otherwise you can't give the medication for long time. And as you know, PCOD is a long-term disease. It's a polygenic, and it is going to last for a long period. So they might take it for 6 months, then they will go to another doctor and tell, we took this, but once we stopped, it came back to normal. So counseling becomes very important for these young girls. Why it has come? And definitely stress brings out the genetic. They might be very thin, but they might get predisposed with the stress and their lifestyle. So counseling and immediate stoppage of bleeding with the Tranexa, then controlling their anemia, and then progesterone. If it does not work, then you go and start OCPs as a last try.
Only one question I wanted to, everyone's asking, for how long will we give the first trial of the OCPs?
OCPs can be given for 3 months.
At least, to start
yeah,
with.
Yeah.
Okay.
Give for 3 months, and during that 3 months, clearly they have to reduce weight. So another thing you can add on after that is, you can add on metformin if they have symptoms of hyperinsulinemia or insulin sensitivity.
Okay.
So
there's one
metformin
question.
probably does play a significant role in this patient because she's quite obese.
And hyperinsulinemic features.
And all that. So probably in this patient,
if you are doing a fasting insulin and it is really high, then it makes sense to start. But otherwise you have to see the motivation, how it comes, what is that patient is going to do. So if she's not losing weight, how long can you give metformin? You can't give it for lifelong, right? So since she's a young girl, so if you're treating for infertility, that's a short period. That is a different area where you begin with metformin in the beginning. But in this girl, we would want her to really understand her problem and lose weight, because weight loss is 5% of her weight loss can give us regularize her cycles, get everything back to normal. And of course she's going through stress of exams and depressed and things like that. All that getting back to normal, things will come back to normal on its own. So let's not hurry up in starting metformin for these patients.
Okay.
I just had one question. If it's a lean girl, we can't advise weight loss. So how do we advise for exercise? They say that I'm already thin. What more should I do? So how do we advise them?
See, what we have understood is this thin PCODs are really difficult to treat because they have more of genetic predisposition than the lifestyle that has changed. But we do see that if they continue to do some exercise, whether they are thin or fat, whatever, that exercise can bring about some amount of improvement in their
In the PCOD.
FSH levels. Yes. So other things again, metformin and other things follow, but exercise is a must. If they're thin or fat, doesn't matter. Exercise is a must.
So I remember one of our senior endocrinologists telling the first, second, third, fourth, and fifth treatment in PCOD is exercise and lifestyle.
Exercise.
Yes.
Yeah.
Yes.
Only number 6 becomes your whatever medications you're choosing. Okay. So now, just in between, going back to the investigations, would you prefer a pelvic scan or would you prefer a transvaginal? Is there an advantage of doing a transvaginal over a pelvic?
Only if married.
This is an unmarried girl, so
Unmarried girl.
there is no question of transvaginal scan. But
Yeah.
otherwise, if you're looking at infertility treatment, yes, transvaginal scan is much better.
Okay. And all of you should remember the contraindications for giving hormone OCPs. At least, can you enumerate for 2-3 major contraindications, Smita?
Any major liver disease, thromboembolic events, ma'am?
Okay.
Any major liver diseases, ma'am?
Okay. So few answers.
Then high BP,
Okay.
hypertension.
Hypertension. Okay.
DVT, migraine, breast
Hypertension.
malignancy. Yeah.
Migraine,
CVT,
ma'am.
migraine.
And all cancers.
DVT. Yeah.
Vascular headache, most importantly, vascular headache, past history of
Vascular.
any thromboembolic events, past history of family
OCPs can be
history of
quite dangerous because a normal looking woman walking around, we will think she does not have any of the symptoms. She'll end up in a CVA. So we have seen a lot of women coming like that, perfectly all right, and ending up in the ICU with a stroke. So it is very important before we start off, because they are going to take it for at least 6 months. So initial 1 or 2 months they may not feel anything, but third month onwards it's very dangerous. And it is important that you monitor your patients, and the first sign of headache, do not forget to get an MRI or a thing, refer to a neurologist to rule out a CVT. It's very common.
yes. So in fact,
Ma'am, can we wrap up this case
we
in
wrap-
another
so
3 minutes?
yeah, I think fairly we have covered now what investigations to do, what are the treatments to be given, and long-term prognosis. Smita, what would you say about her long-term prognosis?
Long term, ma'am, she's more prone for metabolic syndromes.
Okay. So how often
And
would you like to monitor her? How often would you like to monitor her? Not just for the cycles, but would you like to monitor her other parameters?
like lipid profile, fasting, and FBS and PPBS, ma'am, HbA1c, and HDL levels
So
for
our
metabolic
COG, I
syndrome, ma'am.
think,
Maybe the lipid profile.
yes,
And OGTT can be done, ma'am.
Yes, our COG recommends at least from the age of 30 very regularly, but for some patients, if needed, even before 30. So we should be keeping, I think you're fairly covered almost all the investigations that we should be doing. And
There's one question from the audience. Is a scan mandatory to confirm PCOD?
Yes.
Okay. Yes.
Yes.
Yeah, so ovarian volume and the number of follicles.
So the criteria goes 2 out of 3 things, that is symptom wise, ultrasound evidence, and your biological or biochemical or clinical evidence of hyperandrogenism and hyperinsulinemia. So one of this, 2 of this has to be there.
2 out of 3.
So it is very important. See, in the beginning, when you do a scan for a young girl, PCOD might not be that very evident. You might miss out on a lot of parameters, but the same girl, as the age increases, it will be very clear. So that is why they said 2 out of 3 criteria are very important.
Okay.
So in
Ma'am,
this,
can we go to the next case and then continue with the discussion?
yeah, we can wrap up in that. Most important for this patient is to
Yeah.
bring down the bleeding, probably tranexamic acid, then progesterone, and then if needed, a combined OC pill. Most important, and we have to reiterate, lifestyle modification, weight loss. I think there's nothing to replace weight loss in this patient. Okay, so we'll go to case number 2, Smita.
Coming to case number 2, a 29-year-old female married for 4 years. She came with her husband to your OPD with complaints of pain abdomen during the first day of her menstrual cycles. She's trying to conceive since marriage and extremely worried about not being able to. And her menstrual cycles were irregular. Menarche, she had attended a menarche at 13 years. Cycles were 5 to 6 days of bleeding in 35 to 40 days period, and mild weight gain about 2 to 3 kg in the past 6 months. No past history of any significant illness. Personal history, she eats healthy, she does regular exercise. Family history of her father is diabetic, mother is hypothyroid. No contraception used so far, and she has not taken any treatment for infertility so far. And she wanted to discuss her reports with you and take advice on further mode of action. Next, this is her husband's semen analysis, which is actually normal. The counts, the progressive motility is good. Non-progressive motility is around 4, and total count is also good, more than 39 million. It's good. It's normal. And her reports, her hemoglobin is 13.9. Other reports are okay. TCDC is fine. And her TSH is 0.8. And her ultrasound also shows multiple follicles in both ovaries with ovarian volume more than 10 cc. LS to FSH ratio is more than 3:1.
Okay, so now in this patient, we have a different scenario of PCO, and probably your treatment goals are going to be different. So the first question again would be, what are the further investigations indicated in this patient? Smita, would you list the investigations you'd like to do for her and how different it is going to be from the previous patient?
Yes, ma'am. Here we have to, her husband's investigations are normal. So we'll be more focusing on her.
Yes.
Her TSH is normal. Prolactin level we can do, ma'am. And HSG to rule out the tubal patency. And her makes it also AMH levels, ma'am, to know about her ovarian reserve. And FSH and LH ratio, ma'am. That's already been done. So already been prolactin and AMH and HSG. That's what I'm thinking about.
So, oh yeah. So what is the role of HSG here?
To see whether the tubes are patent, ma'am.
Okay, so that could be other reasons for the infertility. So
infertility,
let us
like TB,
so, yeah, so let us think that is normal for all practical purposes here, so that we concentrate more on the management of PCO only.
PCO, yes, ma'am.
So
her BMI is actually normal.
Okay. So in this patient, we probably don't have to look for weight loss, but we have to look for other criteria to consider PCO treatment. Dr. Deepti, can you question as to what she has told about investigations? Is that enough?
So all the others are okay, but one basic ultrasound is very important. That is to rule out other things like fibroid or endometrial polyp or something like that. And if we have any doubt about HSG and further investigation, I mean, that's another level where we also do a laparoscopy and hysteroscopy to rule out further, whether the tubes are open or we have any polyps like that.
So in this patient, probably as part of infertility workup, would you like to do a serial ultrasounds like
yes,
to look at the ovulation?
Going by all the investigations that is done, that is good enough, because we have ruled out the male infertility part of it. We have ruled out the tubal problems. Then coming back to only ovulation. So we have to make sure that she is ovulating well. Though she is a PCOD patient, she might be ovulating on her own also. So an ultrasound, in the middle of the week, or just a follow-up ultrasound in 1 month would help us to know whether she's ovulating on her own or not. If not, that is first thing that we have to establish through ovulation induction drugs.
What would be the best time to do an ultrasound for her? Like you said, one in the mid cycle.
Right. So depending on one on day 2 of a cycle, that is when she's bleeding, to rule out any previous corpus luteal cyst or any other cyst that is there, and see the basal, what is the size and things of the ovary, and the endometrial lining also, whether it's properly shed, is she going to bleed a lot, all those things we can make out on day 2. Then serially, beginning from day 11 onwards or day 9 onwards, if she has a short cycle, we start on day 9. If she has a prolonged cycle, we start on day 11, and based on that day scan, either alternate days or once in 3 days, we follow up to see her, follow up her ovulation.
Okay. So, Smita, what will be the treatment goals for this patient compared to your previous patient?
For her, main concern is infertility, no, ma'am. So
Yes.
we'll be more concentrating on ovulation induction for this patient, ma'am. But before that, a lifestyle modification is, even here, it's very important, ma'am.
So, yeah, how are you going to discuss about what she should be doing, and what is the goal for her? She's already 29.
She's all, yeah, yes, ma'am.
29 years, yeah.
As in the previous case, ma'am, regular exercise, and stress reduction,
Okay.
and even diet modifications, ma'am,
Okay.
to avoid junk foods and stuffs,
Okay.
and include more folic acid, like
Okay.
folic acid,
Okay. So other
nuts and all,
supplements
we can
probably. Okay.
encourage her to take, ma'am.
So what medications you will think
Yes, ma'am.
about for this
Then
patient now?
ovulation induction drugs can be given, ma'am, for her, clomiphene citrate or letrozole.
Okay. Which one would you
Nowadays,
choose? Yeah. Yeah. What would be a
letrozole
choice?
is more preferred these days, ma'am.
Okay. And how?
Letrozole is more preferred from day 3 to day 7. Day 3 to day 7, 2.5 to 5 mg, ma'am, per
Okay.
day.
How many cycles can you
For
try letrozole?
3 cycles, ma'am.
Okay, fine. And clomiphene also, say 3 cycles?
Clomiphene 6 months we can try. That's what the.
Okay.
Said,
Any
ma'am.
other medications you would like to think of for this patient?
Even metformin also, ma'am.
Yeah. So this patient probably we could.
Yeah.
Okay. Dr. Deepti, your thoughts, please.
Yeah. So as Smita rightly said, however she is, whether she's obese or not obese, lifestyle becomes very important. So in that, we need to advise her on the diet. Though she, as you see in the history, she is increasing 2 to 3 kg in last 6 months. So though she's regularly exercising, that is not what is enough. So maybe she has to, you have to give her timeline, as in 1 hour daily or 2 hour daily. This becomes a part of a prescription, so strictly they have to adhere to that. So exercise is one thing. Just telling them go exercise, they will not do. Nobody will do. So it is very, very important that we need to stress on it. If possible, tell them 100 skipping per day or 200 skipping per day. Give them specific things what they have to do. That becomes easy for them to do, either if they're walking brisk walk 30 minutes, 1 hour, whatever that is. And make sure that they're losing weight also. So you need to check them every time they come for consultation, make them aware that they have to lose weight. Otherwise it's not going to happen. It's not very easy to do. So that is one. Secondly, tell them really what diet they have to eat. Just saying that don't eat fatty things, that's not enough. Tell them specifically, avoid sugar, avoid heavy oil and ghee and things like that. So specifically there are some fruits and vegetables which you can say that they can eat, and what they have to avoid, especially red meat. These things specifically we need to tell them. Then it is easy for them to follow. So this becomes the lifestyle part of it. And then, yeah, coming to medications, if she's ovulating, we do not have to give her ovulation induction again, unless you're not sure, because what happens, she might be ovulating on 21st day, so you can't keep on doing ultrasound all the time, right? So in that case, what you can do is you give them clomiphene citrate. That is our first line of management. Again, if she's a patient who bleeds very less, then her endometrium is not very thick. So these patients, when you give a clomiphene, 90% of the time they ovulate, but what happens is their endometrium is very thin, because it acts negatively on endometrium and on the cervical mucus. So pregnancy or take home baby with clomiphene citrate is much lesser as compared to letrozole, or we even give tamoxifen. So that is because it has got a negative effect on the endometrium. So when we give clomiphene, you have to really observe what is the pattern their endometrium is behaving also. So if the endometrium is good, it is giving a triple line, 6 to 8 onwards, and the ovulation it's matching, then it's fine. You can give up to 3 or you can go up to 6 cycles if you're monitoring that cycle. Initially, you don't really have to monitor. If you're in a periphery and getting an ultrasound becomes difficult, you can give them clomiphene, tell them to try for 3 months. In 3 months nothing is happening, then you call them for monitoring continuously. So 3 to 6 months is your time to give clomiphene. Same thing with letrozole. You can give them 2.5 mg to begin with. You start from day 3 of cycle, give till day 7, and monitor them from day 11 onwards. So that becomes easy for you to monitor when you give an ovulation induction drug. Same thing, you can give another, which is a very good drug, especially in my experience. PCOD patients have showed tremendous results with the tamoxifen. So you give 20 mg twice a day for 5 days. So you can either begin on day 2 or day 1 also, or you can start as late as day 5 of the cycle. So give it for 5 days and then again call them for monitoring from day 11 onwards. So that the benefit of tamoxifen, what I myself have observed is the endometrium is very good. Compared to clomiphene, the endometrium really, it is gives a good thickness, and the chances of pregnancy and take-home baby rates are very high. So if none of these works,
question here.
Yes.
Can tamoxifen be given by us physicians before we, refer to you?
Yeah, so that is the next question actually. When will we think of referring to
Referring, because she mentioned tamoxifen, so I thought,
yes.
yeah.
So when would you like to refer these patients to an infertility specialist?
Yeah, we need to choose our patients. Now, giving tamoxifen, if we are to rule out any other breast conditions that she's facing or not, that becomes very important. So there should not be any contraindication to start tamoxifen. But if you are a person who is able to monitor, you can do a TVS scan, you can monitor her and watch. You can always try tamoxifen. There's no harm. Generally, they don't harm. Okay, but don't try it for 3 to 6 cycles, because what happens when you send to a person like a specialist, then they have no choice but to start from the beginning, as in, start with the higher, like gonadotrophin drugs. That becomes a little difficult when a patient moves from somebody like a GP to a specialist. They think that, they started on, they will not continue to go there. So leave it for us for 1 or 2 cycles. You can try it for 2-3 cycles, and if things don't work out, then it is a right time for you to, send, refer.
There is a question on injection HCG. Is it of use in these kind of patients?
Yeah. So what happens is what we give the ovulation drugs is for ovulation. It is only for the growth of the egg. Now, whether it is rupturing or not, there is an entity called as, unruptured follicle. Though it is very less, we do see it quite often in my infertility practice. So when you give an HCG, it is only for the rupture. Basically, you're causing a LH surge by giving HCG. Not a must that you have to give, but if you're monitoring very closely and with very difficulty you've got a follicle, then there's no harm in giving HCG 1 dose, but time it well. And when you give it, just tell them correct time for intercourse. Timely intercourse can be advised to them. Yeah.
What time is the correct time for, are we GPs allowed to give HCG, and if yes, what would be the right timing to?
Yes, you can give. There's no harm in that. It comes as a 5,000 or a 10,000 unit, and it is given subcutaneously. So what we do generally is, if they are trying naturally, you can give it in the morning. But if you're planning an IUI, then you give it in the night, because it takes about 36 hours for follicle to rupture once you give the HCG. So once your follicle is about 1.8 to 2 then you give, 18 to 20 then you give the injection, and then based on 36 hours from there, you roughly can calculate. So if they're having intercourse, then you can give it in the morning. So next day night they can start trying. Or else, if you're planning an IUI in the morning, then you give it, ask them to take it somewhere in the night, so they can come for your preferred timing for IUI.
That's
HCG can be given, no harm.
Okay. Any role for anti-androgen drugs in this patient and even the previous patient for that matter?
Anti-androgen only I wouldn't prefer giving unless they do have a lot of hirsutism and acne and things like that. So where your androgen levels are really, really high. But during when you're planning an infertility, you don't put them only on androgen drugs. You can give it as a combination as an OCP with, as I told you, cyproterone acetate 2 mg comes along with estrogen, ethinyl estrogen combination you can give. So before starting any ovulation induction, it becomes important that you get their axis under control. So you put them on an OCP for 2-3 months. So what happens when they have a very high LH levels? So when you put them on OCPs, they come back to normal. So basically you are switching off their system. And 3 months later, when you induce them, their LH-FSH would have reached that bottom, and then you are switching it on. So when you give, the response is much better.
Okay, so earlier on, not when you're thinking
Yes,
of
no. Before starting the treatment, it's basically to get everything under control.
Okay, so I hope that is clear. So somebody has written injection HCG along with clomiphene induction drugs. Okay, is there a role for both together?
Yes, as I said, clomiphene is for ovulation induction and HCG is for it to rupture. So they are two different drugs and we are giving it for two different purposes.
Okay, fine. So I think in this patient, we can boil down to what we would start off is, of course, apart from lifestyle, it would be maybe anti-androgens early on. Later on, it will be definitely metformin. Probably she will continue it and look for self-ovulation. If there is self-ovulation, probably you can tell them the correct time for intercourse and chances of spontaneous conception also could be there. Otherwise, we could probably think of clomiphene citrate versus letrozole. And yeah, what would be a better option with probably injection HCG at around the time where the ovarian volume, I mean, follicle is around 1.18 to 20, right? So that is what so that is what
when we talk,
as primary care physicians we can probably do about this particular case. And then if still up to 2-3 cycles there's no changes, then we should think of referring to a infertility specialist. So that is what I would call as a gist of this. So there's a
there is
question on
one more thing that I would like to add on. As a physician, you can also look into their vitamin D levels. Because that plays a major role also, as in vitamin D is helpful everywhere. So we don't know what is how much is how much it is helpful, but we have found that there are papers saying that if the vitamin D is less than 30, then there is some kind of insulin sensitivity in them. So what we do is, if the vitamin D is low, you have to measure it. You can't just give them off the record. If it is low, if it's less than 30, just put them on vitamin D, try to correct it. Insulin sensitivity improves, and hyperinsulinemia comes down. So that is another thing that we have found out, which I think initially if you can do that and find out, you can also treat and then send us. So that
So
also
like
helps.
Rita mentioned, I think folic acid, maybe vitamin B12.
Yes.
I've seen chromium being given in many patients. So these kind of things could be, added. Now vitamin D, all these could be added to. I would say the second patient probably a little more important. The first patient also. Maybe I think there it might play a role, but second patient, yes, definitely I think we should start off on supplements
Yeah,
as long.
but make sure you do a test, find out, because there is hypervitaminosis D also, which can be dangerous. So let's not blindly give it. If you want to give it, test first. If it is less, then give it, no problem.
The two questions, I think one is on ovarian hyperstimulation and one is role of injection FSH. So
Yeah, hyperstimulation is quite possible in when we are treating PCOD. So if we have controlled them before we start their ovulation induction, they just don't end up in hyperstimulation. So depending on doses that you're starting. So if you're giving clomiphene in the beginning, you put them on 150 mg. That's a little higher dose. So it's always better you start with the lower dose, 50 mg, 100 mg, and slowly go up. And most of the time, with CC, we have not seen so much of hyperstimulation. But yes, of course, if we start with gonadotrophin, they will be ending up. But I don't think it has to go unmonitored. With under supervision is what it needs to be done. So role of FSH is same thing. So FSH can be given once these oral ovulation induction does not help, then we go to injectable. So there are different protocols on how we go about it. So that's a whole new chapter on its own. So I suggest that don't go into that arena. At least stop at the level of oral drugs and try and push it to a higher center.
Okay, so I think that's quite clear. Now, any role for finasteride, those drugs which you
Finasteride is an anti-androgen drug again. So when they are planning an infertility, I wouldn't prefer. Prior to that, before you do an induction, if you have a documented hyperandrogenism, then you can give finasteride. So most of the dermatologists do give them for hirsutism and acne and things like that. So that's okay, but not when they are on infertility treatment.
as an anti-acne measure, probably we can give all these, I think, no, especially in a
So
young
you can
girl who
preferably give to the younger one. Yes.
First
So probably,
patient.
right,
Yes.
our patient probably, as a boon didn't have all that. She didn't have much hirsutism. But I think if we get a patient, mostly we see this combination also. We see most of them coming obese with a lot of acanthosis, with, facial hair. And probably there is a role for cosmetic, the dermatologist also to be involved.
Yeah.
Maybe younger patient, a cosmetic person like maybe laser or anti-acne stuff, finasteride, those things will be probably important in the first case, maybe not in the second patient. Okay. I think Dr. Bijay has given a comment. The weather in Bangalore is even worse, Bijay. I think in Kerala you are all a little bit, at least having the boon of some sunlight. You come over here, you don't see sunlight for the next 3 to 6 months, I guess. So maybe vitamin D could be a good option. Except that the expense of doing the test, most people may not bear many a time. So it's little difficult to, but then we do get it done also. So next question was, is vitamin D dosage for 15 to 16-year-old girls same as adults? Yes, it is. It is the same as adults. But like Madam said, please make sure you do the test.
Testing
And
before.
yeah, and then only decide on what to do. Joe, how much time do we have now?
Yeah, we have 5 minutes, no problem.
Okay, great. So then in that case, we from Dr. Deepti, we'd like to know what is the latest recommendations on treatment and what is the latest guidelines on diagnosis of PCO?
That's a very difficult question in the end, Dr. Chara. Because PCO, it keeps changing. Every conference we go, there are new guidelines, there are new criteria, and one thing which is never completely understood. So PCOD is like a big Pandora box, very, very difficult to understand, and it changes from person to person, and it mimics a lot of other diseases. So that's one thing about PCOD. But what we have come to a criteria is, yes, the genetic factor is definitely a part of it. Everybody is genetically predisposed, as in PCOD patients. So even if their mother or sister have not faced it, when they have a lifestyle change, as in nowadays stress, not starting their family late, working till late, not eating on time, not having physical exercises, all these are and the stress part of it has changed the person's. That's why we say PCOD is increasing. It's not that PCOD was not there earlier, but it's also understood that it has started much earlier, when the baby was in mother's womb. That is when it has started. Something like famine, and earlier there were a lot of poverty, and as a compensation our body produced too many eggs, and then there were a lot of eggs finally, and now we are facing, because we have a lot of it, now we are facing problem with that. So that is another theory. It's all theory, we don't know the truth here. So PCOD is a lifelong disease, and it can only be controlled. There is no permanent treatment. What we are treating is only the symptoms. If the patient comes with bleeding, we treat that. If the patient has infertility, we treat that. Counseling throughout. And one thing that you have to tell is, it is not completely treated, because if you tell them, it's like a diabetes and hypertension, it cannot be treated. You have to control it throughout your life. So if you maintain your health, if you watch your weight, if you watch what you're eating, it can definitely be controlled. and going forward, if your lifestyle changes, things get back to normal. So these are things, because PCOD can present at any age. We have adolescent PCOD, we have at the reproductive age, and some people do not face any problem because they marry early, have babies, but later on they end up in endometrial hyperplasia, which can lead to CA and all the other related problems of long-term estrogen exposure. So it can trouble us in any time. So right from the beginning, as a child is when they have to be told what to eat and what not to eat. Most likely the children of younger age, they have a early menarche because of that, because they're already obese, they eat a lot of junk food, and they end up so the counseling should start very very early. As a general physician, you will be seeing a lot of mother coming for their problems, but carrying a young girl who's about 8 9 years on her slightly on the obese side. You please catch them at that stage and start telling them, because pre-menarche, I mean, their menarche starts very early for these girls, and they have an anovulatory cycles, which is causing them many years of estrogen exposure. So they end up having a lot of problems because of excessive estrogen. So that is the
So,
best thing because you can do. Yes.
so can it be said that if there is genetic predisposition, like the way you said, if it's hypertension or diabetes, if we have genetic predisposition, then from the younger age group itself, we are, whatever, genetically inclined to have it as we grow older. So that
So
is what it,
you will have the genetic predisposition, but
and then
only
it may develop like
when you have any of these, your
lifestyle added.
lifestyle changes happen, or stress happens, or there has to be some kind of a hit on it, then only
Mm-hmm.
it comes. So based on how
So
your
similar to
lifestyle has
the
been.
lifestyle, yeah.
There
Yeah.
is an
So
autosomal dominant way of,
yes,
I think,
yes,
transmission. So very likely that sisters or mothers,
yes.
aunts have it, and then you. There was
They, earlier, because they used to have early pregnancies, we used to miss them, having to come with infertility problems, because they never had, at the age of 20 they used to have children, but now they start planning only at the age of 30. By then things have gone haywire.
yes. There was also a question on vitamin E supplementation. Is it
Hmm.
beneficial along with vitamin D? So any role
Uh,
for vitamin
I wouldn't say it is beneficial in case of PCOD, but what we see is PCOD, as I told, if there is a long-term exposure, as in she's been having irregular periods and she's been infertile for a long period. When we do an IVF, we see the quality of egg. Uh, they're very bad. The quality of eggs in PCODs are quite bad, though they are young, maybe 20 25s, but probably it is because of the long exposure of hormones and androgens. The quality of eggs have been very very poor. So in these patients, vitamin E, when we have supplemented, we have seen some kind of changes also. So but vitamin E again cannot be given for a long period. It is a fat soluble vitamin, so we have to be really careful. So you can hardly give for 15 days or 1 month max, and that's how about. So I don't think you should be starting vitamin E for this out of the blue. Um, that's only if we find a problem like poor quality eggs and they want to try again, and then we supplement it and see, but not like a blanket therapy.
Yeah. So this point which Smita has put up now, coronary artery disease also, I think all of us should keep in mind. Being primary care physicians, we should be warning our patients chances of coronary artery disease and make sure that we are, giving them adequate counseling, doing the required tests as and when needed to prevent coronary artery disease as they go towards their middle age. You might not see in very young age, but as they go towards, so from 30 35 years of age, I think we should start counseling them very much about the chances of coronary artery disease also. So I think treatment we have almost covered different scenarios and different kinds of patients we see. I think as you said,
There's also one
diagnosis.
more aspect, that is when it comes to obesity. I think we have not touched upon obesity much. We have, yes, of course, we are told about lifestyle and weight loss management, but if they're overweight or they're on the obese side, it is not easy for them to lose that initial amount of weight. So you can help them by starting them on some kind of anti-obesity drugs. So that is one thing.
Ultramin is the only one I think which is
Orlistat, yes. Yes,
Orlistat.
Orlistat is the only drug that is approved, and you can give it for as long as 3 to 6 months under supervision. Or if they're morbidly obese, even recommending them to go for bariatric is another thing that you can do, because they're quite young. They will be hardly 25 years, but they will be 120 kg. For them, if you tell them just go and
Lose
reduce
weight.
weight, it's not enough. You need to counsel them further, help them. It is up to them whether they want to go or not. But that's another thought and another way where you can think about it also.
Orlistat dose and duration.
Orlistat usually it is 60 mg to 120 mg, OD to BD. Normally we can give for 3 to 6 months and see.
At least, yeah, 6 months.
Yeah, I think sibutramine is now outdated because of chances of I think CA or some. I think it was linked to some CA. So mostly we are using Orlistat now.
Yeah, yeah.
So hyperinsulinemia and thrombogenic state may be interrelated, like hyperinsulinemia and PCOS. So there might be a direct chance and association. Yeah, very much. Hyperinsulinemia itself is a state where there is thrombogenic activity. So that is why both ways, the chances of CVDs also is very high. Cost of Orlistat is quite high. As far as I know, it is about I think 60 to 80 rupees per tablet. I'm not sure about any generic on those, but most of the traded ones are more than 60 to 80, I think. Criteria to start Orlistat is mostly if the BMI is over 40. What do you say, Dr. Deepti? Usually when the BMI is over 40, we normally think of starting some, drugs to
Yes,
get the weight
before
down.
that they have to be motivated well. If you know that these people are really doing it, and then in spite of that it's not happening, then you can start, even if their BMI is slightly lesser. But there are people who will be really careless. They're not doing anything, but then they just want some medication. Don't give to them, because it's not going to work. They are simply utilizing your services, but it's not helpful for them at all, and you can't give it for a longer period. So you have to give it when you are planning to give an infertility treatment or something like that. When they are that's the waiting period. As I said, we start on OCPs and they do their exercises. You can also start them on these drugs to reduce weight, so that after 3 months or after 6 months you can start them on ovulation induction. So that's the waiting period where you can do all these things.
Okay, Joe, if there's anything else.
Okay, yeah.
I hope we have not missed out much on the
Yeah,
scenarios.
you can give it just before food or
Before food.
with food. With food, yeah. With food or just before food.
And explain to them that they might have steatoria, because there will be a lot of fat absorption with steatoria and a lot of abdominal symptoms also. So warn them about the potential side effects that they can face. And
Know your drug well before you start it on a patient. So because counseling becomes very, very important. So you should know the drug in and out, where it is indicated and where it is contraindicated mainly. Even metformin, it is contraindicated in some people. So clomiphene, it's contraindicated in some. So OCPs. So always know where it is contraindicated. You can always give the drug. It's not a big deal. But the side effects is something you should know before you start your drugs.
Yeah. Okay, so I think it was a good session, and can we wrap up? So I'll call Dr. Kailas, who's the FM 360 coordinator, to give the vote of thanks.
Hello, everyone. I think I'm audible.
Yes.
Yeah, this is our second Spice Root classroom, and after the first one, we are very eager to conduct the second one, and we have to continue the pace. Then only will be a huge success, and we will be planning for more and more classrooms in the coming months. And thank you, Spice Root Karnataka, for organizing this in a very effective manner. And I would like to take this opportunity to thank our chief guest, Dr. Kinley from Bhutan, who is a nice friend. And thank you, Kinley, for being a part of us through the whole classroom. And next, I would like to thank Dr. Deepthi, who accepted our invitation and be a part of, and guide us regarding the management of PCOS in various scenarios. And thank you, Dr. Deepthi, for being with us. And I would also like to thank Dr. Swapna ma'am for moderating the event and helping out the young students, young PGs from all over India. And a very big applause to Dr. Smita for nicely presenting both cases in front of a huge crowd here. Is like it will be a great experience for you in your lifetime. Thank you for being a part of us. And I would like to thank all the senior members of AFK who came with us, Dr. Rashmi, Dr. Mohan, Dr. B.C. Rao sir, and many others who joined us today and making this event a huge success. And we would also like to add, thank all the members from India and outside India who has joined us in this meeting.
Yeah, we have few guests from Pakistan as well.
Thank you all. And yeah, we have people from Pakistan, we have people from US, etc. has joined us from UK. Thank you all for being a part of us, and we'll see you all for the next special classroom next month. Thank you.
Thank you so much for the
Thank you.
opportunity. Thank you.
Looking forward to
This session, yeah, this session will be available on YouTube for viewing at any time for anyone who's missed it. So you can share it with your friends, colleagues, or whoever has missed it on the Spice Root YouTube channel. Thank you everyone.
all of you.
Thank you.
Bye.
Thank you, everyone. Thank you, everyone.
Thank you.
Thank you and good night.
Thanks, Kinley. Good night. Bye.
Good night. Bye-bye.